Hello, good afternoon. Thank you for sharing your lunch hour with me. Um, I'm one of the pediatric surgeons at Texas Children's. My specialty is pectus and chest wall deformities. Head of the pectus program here, and we've had a great experience changing the lives of many, mostly adolescents, but some adults. And I just wanted to share some information with you today. And again, thanks for joining. So I am a consultant for Zimmer Biomet, which is they make one of the Pectus sets for the equipment, and I'm just a temporary consultant for the new Pectus set that will be coming out hopefully in the next year or two. So this is a picture of someone with a Pectus excavatum, which is something that will pretty much dominate most of the discussion today. And we're going to go through many aspects of what it is, how it happens, and how to treat it. First of all, when we look at a chest wall, I think one of the most important things is to understand the anatomy of the chest itself. And pectus chest wall deformities clearly are based on the anatomy you're seeing here. There are only a few bones in the chest, the sternum and the ribs, which people are very familiar with. What we're mostly focused on when we see pectus is the costal cartilages. So you can see here that in blue, you'll see the costal cartilages connect the end of the ribs to the sternum, and then they compose what you call your rib cage, or what we call your costal margin. And I sort of highlighted some of the more important ones here, because when you look at a pectus patient, a lot of the abnormalities you'll see will be inferiorly on the excavatum patients. And usually for a carinatum patient, which we will also talk about later, it'll be on the sides. So just keep this anatomy in mind. And specifically the lower parts, which I have the little laser pointer here, because I'm going to talk about what's called rib flaring a little later in the talk. So just to keep that in mind. So pectus excavatum, this is a very common chest wall deformity. And actually, you'll see it in about 300 or 400 people, every 300 or 400 people, mostly in males, which are, you'll see more than females, 4-to-1 ratio. Like I mentioned previously, it involves the lower sternum typically and the costal cartilages. And you'll see this around usually 2 times in life. Typically, it's either in infancy or more commonly around the time of puberty. In fact, you'll have many parents come to you and say, he wasn't like this even a month ago. And you'll see a very deep pectus excavatum patient in front of you. So it can be a pretty dramatic change. Plus, kids have a way of hiding things, so they can wear shirts and hoodies. And you'll never know. They have it for maybe several months to a year or two. What you may notice is they stop going to the swimming pool or to the beach, that sort of thing. Now, the cause of pectus excavatum, and this is true with the carinatum, is really unknown. People have actually studied the rib cartilages themselves and looked for genetic mutations and things like that. And we really haven't seen any of those things. But we have seen some familial inheritance in a very unusual way, meaning some patients will have an excavatum and their brother or sister will have a carinatum. And it's about a 19% family incidence of that. You also see it more commonly in certain genetic syndromes, such as Marfan syndrome and Loeys-Dietz and Noonan's, and also in Ehlers-Danlos. So in those different patients, you may see patients with a pectus, and it might actually lead to some different changes in your operative strategy. So people have studied these patients for many decades, and there's only some consensus on what degree of cardiopulmonary impairment there is. From a pulmonary perspective, we do see some changes in muscular ability and patient effort, specifically FEV1 and forced vital capacity, but not total lung capacity. And you'll see decreased transport of oxygen to the tissues that need it, measured as a VO2 max when you do exercise testing. From a cardiovascular function, you'll see indentation of the right ventricle, which is very universal. And you'll also see a stroke volume problem when they're exercising. They will compensate to contribute to their cardiac output by increasing their heart rate, but their stroke volume suffers greatly, and many patients cannot increase their stroke volume at all during exercise. And you also see mitral valve prolapse, which is just mostly for interest and doesn't really cause a physiologic problem in these patients. Some of the best data we have is with body image. And these psychomotor assessments that many investigators have performed have shown huge improvements in body image and psychosocial functioning in these patients. So how do we actually evaluate a patient with a pectus excavatum? Well, one of the things that's very important to us as surgeons is a CAT scan. And it's a non-contrast CAT scan, so they don't need an IV. It takes very little time. You can get away with an MRI. Plain x-rays are usually not very helpful because of the rotation of the patient, and you really can't get that exact lateral view to calculate a number that I'm going to talk about in a minute. Another thing that we look at is pulmonary function testing, which is pretty much done on every patient. And then in select patients, we will actually order an echocardiogram. And the echo can be very helpful in determining, especially during stress, if they're having these stroke volume problems. So just to give you an example of what a CAT scan would look like, and I think I lost my laser pointer, but hopefully you can see my mouse. This is the sternum in the front. This is the spine in the back. And the heart you can see in the middle is this gray circle. And then these other white parts on the chest wall are the ribs. So I've just sort of accentuated the fact here that the heart is a circle in a normal chest. So this is completely different in a pectus excavatum patient. So you can see the front on the previous slide is straight across. There's no indentation. Here you see the pectus from the external, you can see the skin. And what we really look at is the costal cartilages and the ribs and the sternum. And you can see this heart is completely compressed. This is another example. Now this pectus is so deep that there's really no room for the heart between the back wall, the sternum, and the front of the spine. So in this patient, it exists only in the left chest. It's been completely moved over. So one of the ways that we actually look at severity, so this is important for our anatomy, to know how the heart is being moved and compressed, and also for sternal torsion. But one of the other things that we want to know about is there a way to objectively measure the severity of a pectus? And there's actually two ways to do that. One is called the Haller index. So we'll go up and down on the CAT scan. We'll find the deepest part of the pectus, and at that point, we'll draw some graphs across the left to right transverse diameter, which is the numerator, and then we'll have a measurement from the posterior sternum to the spine, which is the denominator. And this gives us a ratio called the Haller index, named after Dr. Alex Haller. And this tells us severity. So if that ratio is above 3.25, you're considered to have a severe pectus. That is actually something that can be altered by just your transverse diameter. So if you have a really broad person, they're automatically going to have a Haller index. If you have a narrow patient, they're going to have a lower Haller index. So there's some faults to that measurement. With what we call the correction index, there are really no faults. This tells us if we return the sternum to where it's supposed to be, what % space do we gain in the middle of the chest? And of course, that gained space will be all in the benefit of the compression of the heart, and hopefully we completely relieve that. So for a correction index, it's significant if it's above 10%. So let's just look at our indications for repair. We'd like our patients to have symptoms, and most of them do. We don't like to do it just for cosmetics, because that's not really what we go for. We look at restrictive disease, other things that you might see on PFTs. We talked about the Haller index and the correction index. Any cardiac abnormality, including mitral valve prolapse or any arrhythmias, including bundle branch block, is an indication. And then another indication would also be a recurrent pectus after a failed repair. Now, our choices for repair are two, and I can tell you that pectus excavatum is essentially a surgical disease, although we'll talk a little bit about that in the non-surgical category in a minute. So for surgical disease, we have two options. One is a ravage repair, which I'm actually going to talk about when we talk about carinotums, because it's no longer the gold standard for repair in these patients. And the other one is the Nuss procedure, which was originally done in the late 1980s. And Dr. Nuss recorded his 10 years of experience before actually reporting his results. And that's why it's called the Nuss repair. Very innovative technique to repair the Pectus excavatum deformity. Now, I would normally have some actual photos in the OR here, but we're going to just show you some drawings in this circumstance. So we have our patient with the obvious Pectus excavatum deformity. We have a tape measure across the chest here. We're measuring from mid-axillary line to mid-axillary line. That helps us determine what size bar we're going to use to repair the defect. At the bottom, you see a straight bar, which is here, and then a curved bar, which is here. All the bars come straight. We bend them to the shape we want the chest to be. And this is how we use it. We use some specialized tools. On the left, you see the straight bar. On the right, you see the final result. This is the shape that I want the chest to conform to when we place this across the mediastinum. And the bars I use, I like to use stainless steel. They're a lot cheaper than titanium. You may use a titanium bar if someone has a metal allergy. So, but that's a pretty rare problem. We also may use what's called a stabilizer, which is a little crossbar that slides onto the end of the bar on one side, and that does prevent the bar from rotating up and down to some degree, although if the forces are very great, it will still rotate. So back to our diagrams. So we mark the chest with these X's, so that's where the bar is going to actually go under or inside the chest, under the sternum, and then come out on the other side. Our incisions are pretty lateral. You'll see that there's a camera here that we're using to visualize the inside side of the chest at all times. That's why the safety of this, that's why this operation is extraordinarily safe. We dissect under to the X's from these incisions, creating a little subcutaneous tunnel. And then we pass an instrument, which some people refer to as the sword, under the sternum, and you can see we have to fit in this very narrow space between the back of the sternum and the front of the heart. The pericardium is very protective in this circumstance. Also, our instruments only point up towards the sternum. They don't point towards the heart. So to have a cardiac injury is exceedingly rare, and probably only will happen if someone's had multiple sternotomies in the past. Even in that circumstance, you can prevent it. So the bar passer, which I told you is sometimes called the sword, is passed all the way across. You get correction of the deformity in that circumstance, but obviously you cannot leave that instrument in place. So you want to then pass your actual bar into place. So here we are just passing some umbilical tapes back out through the other side. We then attach those to the bar. The bar gets placed actually upside down, meaning the C configuration is the ends are pointing up. And then when we turn it into place, it corrects the deformity, and it does it immediately. Now, the bars can be configured in many ways. One bar is sort of the standard with the upper left here, one bar, one stabilizer, but not everyone's chest is identical to another. So you want to really custom fit the repair to the patient. So a one bar in one person may not correct maybe only half of their pectus in another patient. So sometimes you need two bars, sometimes you'll add stabilizers, sometimes angled bars are appropriate, and I'll talk about that in a minute. And sometimes an X configuration is appropriate and provides automatic stability because the bars will sit against each other, and because there are flat surfaces, they'd rather sit against each other than turn in any way. Just some examples there, and here's some operative pictures. So you'll see that this is quite a hairy patient, and my patients are usually not this old, although I do operate on adults because pediatric surgeons are the ones that sort of know how to do this operation compared to adult thoracic or cardiac surgeons. So in the middle, you see a template bar. That's a very bendable bar that's just used to sort of decide what size bar we want. And then on the right, you can see the actual repair, and you can see we get immediate results before we leave the operating room. Just some more examples here. On the left, very deep pectus. On the right, corrected chest wall. You'll also note in the next picture that I'm going to draw some arrows in there. And the reason I bring that up is what I mentioned earlier, which is rib flaring. Rib flaring is where your lower costal margin sticks out. It's a little bit of a vexing problem for us pectus surgeons because we're great at fixing the pectus. We're difficult at, it's hard to fix the rib flaring. So we're going to talk about that a little later, but I wanted to bring you, make a point of bringing your attention to this. Here's another example. Again, a really outstanding repair. More examples. This is an older patient who actually had an extraordinarily deep pectus. He also had what we call a sternal cleft. So he had a hole in his sternum. And so what we did was not only repair the sides and actually put more bars across, we also did a sternal repair with his cleft. And we have hardware in the middle and this little incision in the middle to correct that. But you can see he has a very flat chest. He's a paramedic. He's gone back to work. He has a very, very happy lifestyle at this point, much better than before. Now, this is an interesting patient. This is a male who has a large breast on the left, gynecomastia. And in the middle, you see his intraoperative photo, or at the end of the operation. We've done both a pectus repair and we've resected the chest wall, or the breast mass on the left. And this is a couple weeks out from surgery. These incisions are going to fade. These are pretty fresh. And what you'll see here is some incisions in the middle. We actually can use an instrument to pick up the sternum in the middle, decrease the pressure that it takes for us to get under there to correct the chest wall. That's obviously done during the surgery and has also provided a level of safety for our patients. Now, I sometimes refer to this repair as like wearing braces for your chest, except when you wear braces on your teeth, that's a gradual repair, and this is an immediate repair. An immediate repair, as you can imagine, if someone were to tighten your braces for your teeth all in one day and straighten them all in one day, that would be extraordinarily painful. And that's essentially what we're doing here. So we know that our patients have some pain concerns, and we've typically focused on that for our post-op recovery more than any other thing. Over about 3 years ago, we decided to change our pain management because our patients were having to stay about 6 days. And that was regardless of what technique we used. You know, thoracic epidurals, nerve blocks, PCA pumps, on-cue pumps, all sorts of things. So we added this new technique, which actually not new, it's been around since the 60s, but it's new for pectus. It's called cryoablation. And I'm going to talk about that a little bit next. It's allowed us to keep our patients in the hospital for only about 2 days, and they recover a few weeks at home. When they're fully recovered, they can participate in all activities with the bar in place. I'll talk about cryo in a minute, but just because I usually skip it and forget to talk about it, the hardware that we put in the chest comes out at some point. And the reason it comes out is you can't really do CPR very well with the hardware in place. Luckily, most of my patients do not need CPR. But as an older patient, you might, and so we need to have the hardware out and get that compliance back to the chest wall. So the bars usually come out in about 3 years. So this is just a little movie about cryoablation. Hopefully you guys can all hear it.
We're not able to hear it, Dr. Maziad.
Okay. So what it's saying is that the cryo nerve block helps us freeze the intercostal nerves, which are under each rib. And we actually do nerves 3 through 7 on both sides. What's going to tell you here is that the nerve has an outer protective coating called the perineurium, and the nerve is runs on the inside. When we freeze the nerve, which we do with direct vision, we don't mess with the protective structure. We do freeze the nerve, and it grows back over time. So while it's asleep and frozen, it will not transmit sensation to the chest wall, which also blocks the pain fibers. So that allows our patients to feel basically nothing in the front of the chest. And over time, it comes back. Their sensation, even at 2 weeks, is back to 10 or 20%. And then by 3 months, it's back to 100%. So blocking the sensation and the pain fibers contributes to exceptionally good pain control and a much better outcome for our patients. So much better that we studied it and reported it. And we looked at our NUS procedures from 2016 to 2020. We compared intercostal nerve cryoablation with a standardized pain regimen compared to any other pain regimen, any other analgesic method, including thoracic epidural. And we looked at these data points. And what we're mostly looking for is, are they using less narcotics? Are they getting out of the hospital faster? Are they decreasing the refills of narcotics as an outpatient, that sort of thing? And then does it actually change the amount of complications or the outcomes? So this graph is very telling, and I want you to look at the dashed line compare at postoperative day 2. So the red line is the alternative pathways of pain control, and you can see that well over 80 and almost 100% of the patients were still in the hospital on postoperative day 2, no matter what you did. In the intercostal nerve cryoablation group, which is the blue line, only 20% of the patients stay beyond day 2. So the 80% usually go home on day 1, day 2, and about 20% will go home on day 1. So looking at it a little more detail, what else does it benefit? Well, urinary retention is dramatically less. Why is that? Because we're using a lot less narcotics, and that's what gives you that. They also are more alert during the day. Allodynia is something that we did see increased, but it wasn't statistically significant. What is allodynia? That's a hypersensitivity in the nerves that we froze. All right, and you can see it also occurs in other analgesic methods. I will talk about that in a moment. We did notice that our risk of any complication was a lot less when using cryoablation, and that's mostly accounted for by the urinary retention data, but it's nice to see that pretty much if you count all complications altogether and add cryoablation, we have better outcomes. But things do happen. Bars do move. You can actually break someone's sternum during the case. You can see on the left lower one, you see a bar that's rotated upwards. And then you see the postoperative when we reoperated on the patient on the right in the middle. And on the right, you see a lateral CAT scan with a broken sternum. We do have a better stabilization technique as of approximately 6 months ago. And using that technique, we've actually had 0 bars migrate or rotate. So we're very happy with that. Getting back to allodynia. When you look at this person's chest, and he's post-op repair, he has a good-looking chest wall, you'll see while he has this rash on his chest or something, when you actually rub it with an alcohol wipe, which I did on the right side of this picture, you see that it's actually dirt or hypertrophic skin. And when I'm trying to rub with an alcohol wipe, he hates it, right? He doesn't want me touching his chest. That's that hypersensitivity I'm telling you about. It's rare. It does happen. The good news is we treat it with gabapentin, and it goes away. And we haven't had anyone with long-term problems with it. So it's less than 4% of patients and temporary. So what if you had a patient that you didn't want to do surgery on for various reasons? And I can tell you that in the patients that I've shown you and older patients, it is the gold standard. Surgery is the gold standard. But in younger patients, who knows? So there is a vacuum bell that we can use, that we can provide to our patients. And the patients that are the best candidates for this treatment are the young, very flexible patients. Trying a vacuum bell on a patient who is 20 years old is not going to work. It's not going to move their chest wall. Those costal cartilages over time will calcify, and they'll become problematic with trying to move them. Even in the OR, it's harder to move the chest wall in a patient who's older than in a patient who's younger. So on the left, we have a measuring tool to measure how deep the pectus is. On the right, we can see the vacuum bell in place, and what it's doing is it's pulling the sternum up. If we can do that for several hours a day, we can change the actual shape of the chest wall. This is a patient who has a vacuum bell, and here he's applying it. I'll see if I can show you this movie. So he pushes to start some vacuum. Then he uses the vacuum, like the sphygmomanometer ball, to suck air out. So his chest is actually going up, and it's raising it. And our actual goal is to do this 2 hours twice a day. You'll notice that he does have some changes, even in the short time where he's wearing the bell. So you'll see it on the right here where he removes it, takes the suction away, it pops off, and you can see that he's got a red mark on his chest, which will fade rapidly. But we don't want to do this all the time or for long periods of time throughout the day, because you can get a permanent change in your chest wall in the skin, and we do not want to cause damage. You'll see this also applies to our next pectus deformity, which is called a carinatum. And this one's a non-operative treatment, essentially, although you'll see there are some cases where you might operate. So this is a pretty substantial and severe pectus carinatum. In these patients, you'll see that they look differently. That's essentially the inverse of an excavatum. It's much less common than an excavatum, unless you live in Argentina, which has the highest percentage of people that have carinatums in the world. The cause of a carinatum, also unknown. We talked about family history. The one thing I didn't mention with an excavatum, but is true, is that in both excavatums and carinatums, scoliosis is an association. It doesn't affect what we do. It doesn't affect how we repair the defect, but it is something you should look for in your patients, and is present in about 15% of them. So, like I mentioned, it's a non-surgical treatment, essentially, although you may do some surgery, and we'll talk about that in a minute. So, one of the old-fashioned braces that we used to use looks like this. And this is something that is basically padded in the middle. The patient wears it, you say tighten it as tight as you can, and hopefully it makes a difference. And I can tell you that while following people over a couple years, it didn't make that much of a difference. It wasn't very beneficial, unlike the system we use now, which is actually from Argentina, and it's called dynamic compression bracing. So you see this little pressure device in the middle, and you see 0.00. Well, when you press it on the patient's chest, you can determine what the pressure of correction is for these patients. And then the brace can be made to create that pressure. So it actually uses science, which is a novel idea, to actually correct the deformity. So when they wear the brace, and you can see also on the left side, you'll see this little silver snapping locking mechanism. So when they snap it in place, we've designed the brace to have the exact pressure of correction we need. So when they wear it, they will get correction over time. Now in these upper two anterior pictures, you see a red splotch on the right side. That's now a lot of carinatum patients are asymmetric. One side sticks out more than the other side, unlike the first picture I showed you, which was pretty symmetric. But most of them are asymmetric. So you want to move that pad to the point where it does the most pressing, and you might see some redness like that. But that's obviously a transient thing. It's not permanent. This is someone who just took their brace off. As you can see, especially in the lateral pictures at the bottom, we're really getting good correction of the deformity. Here's another example. One patient, and these are over 2 to 3, maybe 4 months. So much quicker than what you would normally see with any other type of treatment plan. And here's another example, all lateral pictures here. but a much flatter chest. Now, for these patients, they don't have a lot of symptoms. It's a lot of psychosocial issues typically. They can be pretty profound with regard to them being reclusive and not participating or in social activities. This really helps them get back to doing things like any other kid. Now, I had mentioned rib flaring a couple times in the talk. Rib flaring is mostly a problem with excavatums, not with carinotums, even though I just talked about that. But the reason I'm bringing it up here is we can use our pectus brace, and you can see rib flaring very classically at the top, very protruding a lot. And here we can use it to flatten those areas because it's all cartilage. We can change it over time as they grow, and we can use this to our advantage to improve these patients. I'm just going to talk a little bit about surgery for carinotum. Again, some more pictures. These aren't as good as the other ones, but essentially what you're doing is creating a transverse incision, raising the pectoralis muscles. You're actually removing those cartilages that we talked about, and you leave the lining to the cartilage so it can grow back properly. So you don't take the whole thing out. You take the middle out. And then over time, they grow back. During that time, their chest is not stable, so they may have to wear a little shield on their chest. But you can get actually a very good result. You may have to cut the sternum and flatten it. And you might do that with a plate or some wires. And then you bring the pectoralis muscles back together, reapproximate everything, and you can get a great result. Now, even though that incision is not huge, there was a lot of surgery that went on to do this. This takes about twice as long as correcting an excavatum. And we leave a drain, which is what you see sticking out the bottom there. You can also do an operation which I sort of developed here. It's actually developed in Argentina, but they have their own equipment. I used our usual Pectus excavatum equipment to do the same operation. And what we do is it's called a reverse Nuss procedure. So on the left, you see the pectus carinotum sticking out, and you see two, what I drew arrows to are these anchor points. We want the pectus bar passed subcutaneously, so unlike an excavatum, which is under the sternum, this is under the skin only. You see that pressure arrow in the front, we press down on the front of the chest, and we lock it into those anchoring points. And that corrects the pectus. And you can even correct someone who has an asymmetric carinotum in this way. This is a close-up of one of the anchoring points. Again, this is the standard equipment we use for an excavatum repair, except here we're using it to correct a carinotum. And this is an example. You can see this gentleman has a very asymmetric carinotum, sticking out much more on the left side than the right. When we do our reverse Nuss, we have an outstanding result at the bottom. That hardware also comes out after 3 years. This is what a reverse Nuss looks like on a plain X-ray. There's a little more wire in there, but it's covered very nicely, and they are allowed to do all their normal activities after they fully recovered from this repair. So just wanted to sort of summarize here. Most of our Pectus excavatum patients are symptomatic, and they do suffer mostly during exercise only, not at rest, and they complain of shortness of breath, chest pain. They have fatigue. They can't keep up with their peers. It becomes very frustrating for them. The carinotum patients, like we talked about, usually it's more of a cosmetic thing, although they can have some chest wall pain in those affected areas. For excavatum and carinotum patients, they both suffer from psychosocial issues, although they usually deny it in the clinic. And just to generally summarize, most excavatum patients require an operation for repair. Most carinotum patients require non-operative treatment. This is our Pectus program. Although I sort of head the program, I'm not the sole provider. We have many people in my group that do Pectus repairs. We do them across 2 campuses currently. We will be doing them in Austin, and we will also be doing them in the Woodlands, hopefully within the next year. Our APPs are exceptionally gifted with regard to helping adjust our braces. We generally see the carinotum patients as an initial visit, And then the APPs are the ones that actually fit them for the brace, adjust the brace over time. They've had outstanding results, again, only over a few short months. Probably our longest delay is actually getting the brace from Argentina, which it has to go through customs, so that can take a good 6 to 8 weeks. Then at the bottom on the right is Vanessa Mose, who is my administrative assistant, who deserves thanks because she fields hundreds of calls probably a week regarding Pectus patients, and she does an outstanding job. She's very experienced. Just wanted to let you know that I'm happy to answer any questions, and I wanted to thank you for allowing me to speak to you today. And I think we'll go to the questions next. Okay, so the question was, as a pediatrician, should you order the CT or just refer to me? And I think that can be done one of two ways. If you have a person who, I honestly don't like irradiating people for fun. So if I'm going to see someone in the clinic and they're vehemently opposed to surgery, then I'm actually probably not going to order a CT. It's not a good screening tool. So, and if they're out of the vacuum bell age, I don't see a big utility for that. So if they are very interested in surgery, and I know that, and I've just told you that's the main treatment, and they're very interested in it, it doesn't hurt to order one. You just order a non-contrast CT. It can be done anywhere or at ARA. I can look at it. People can also get it on a disc and send it to me. So I would say, if you're in puberty and you're interested in surgery, CT is fine. If you're very young, I wouldn't do one because I don't do it for my bell patients, vacuum bell. And then I also would do it if someone's not interested in surgery.
Okay, next up.
Next question.
Next question. Other than the need for revision, what other complications do you normally see, and how often are there complications?
Great question. So complications are very rare. People seem to think that everyone has an allergy to metal, which is untrue. In fact, the data that's out there has since been retracted. It's very rare to have an allergy to metal. If they do have an allergy to metal, they're not a non-surgical candidate. We can use a titanium bar. It just costs 3.5 times more for a titanium bar. So I tend to be cost conscious. And I think that it's also hard to use a titanium bar because it's not very malleable. I can't bend it and customize it like I want. So one thing people can talk about is allergies, but I think it's not really founded. Infection hardly ever occurs. The main thing that is our bugaboo is movement of the bar. There are a lot of stresses on the bar. The chest wants to go back to the shape it was. So we have to counteract that and stabilize the bar where it is. So we really restrict them for the first 2 weeks because that's usually when a bar is going to move. And so movement of the bar would be probably the main thing we look for. You can also get pleural effusions, which are rare but might require drainage. That would be if you're doing a lot of operating in there, passing lots of bars, you're not quite happy with the repair. Other things could be a cardiac injury or a lung injury. Those we don't see. And I will, to this day, say this is almost safer than a hernia repair if it's done the right way.
So talk a little bit more about the metal allergy and the hyperpigmentation. Is it the metal allergy that causes the hyperpigmentation?
No. So with a metal allergy, you would see probably bilateral pleural effusions and a big red streak across the chest, which could also be infection. So it's hard to rule those out or to tell the two differences. I can tell you I've done almost 500 Pectus repairs. I have never used a titanium bar. So the metal allergy, again, is overblown and incredibly rare. We do test people who have abnormalities with wearing jewelry and the snap on their jeans, things like that. Usually they don't come up to be very reactive, and it's patch testing that we do. The rash that I showed in my presentation is from allodynia. It goes away when they have good sensation again and when they're able to wash their chest. If I can wipe the dirt off their chest because they're not washing it at all when they're scrubbing it during the shower, it's not really a rash, it's more dead skin cells.
What causes it after an operation like this?
You can get what causes the rash.
Yeah.
One thing you can actually get a red rash across the chest from cryoablation. It's a very transient vasodilation of the skin vessels and tends to go away in a few days. And then this one, they're not really sure what causes it, but I have seen it in a few patients. I think it's because they don't wash their chest. They will not take a wash rag to it or anything. They avoid it completely. So getting their pain, their sensitivity under control is a big thing for us. And when you see that guy back in a month or two, he's going to have a normal chest.
Okay. So it kind of takes care of itself, but
Yeah.
you can speed it along.
It does take care of itself, but they're very uncomfortable. And so I really have to intervene with some medicine. I think it's the right thing to do.
Okay.
The company will tell you that it'll just go away. But I've had very good success, and I think it goes away probably faster if you treat them with gabapentin, Neurontin.
So let's talk sports and Pectus problems. Would you clear an asymptomatic Pectus patient for sports before being evaluated by a team like yours?
Yes. So just because their chest is shaped differently doesn't mean it doesn't have the same structural integrity. So again, people have studied these cartilages. They've studied the shape. They just think maybe there's a little change in the collagen, but it's not that they're weaker. They're still very strong. They still protect everything on the inside, which is what your chest wall is supposed to do. So I let my patients do all sports at all times without limitation. This is not subaortic stenosis where they drop over on a football field. Yes, they may have fatigue. They may have to come out early, maybe want extra rests, but they're not going to have a significant cardiac event. I clear them to do all sports, no matter how deep the pectus. And in fact, there was a Pectus patient in the Summer Olympics last time, a swimmer, pretty apparent. You could see his chest on the screen. So I can't tell them not to do sports because I think it's very safe. I think they should clear all physicals, even with a severe Pectus.
And what about measurements? Do you measure the carinatum patients similarly to the excavatum patients?
You can use the Haller index to measure a carinatum patient, but you would want a CAT scan. So for a carinatum, I don't do a CAT scan. I probably should emphasize that in the talk. For a carinatum, we just look at you and examine you, and then we do a bunch of specific outside chest wall measurements using calipers and pressure measurements. But we don't use imaging that much. Having said that, our cardiologists feel that the carinatum patients are at higher risk for connective tissue diseases, and so we tend to order echoes on them to look for that. I'd have to say, with my experience of that over the past few years, I have not identified many patients who have that problem, but I think it is, at least until it's published otherwise, probably a good practice. For the excavatum patients, we don't typically do echoes. So we don't typically measure, the short of it is we do different measurements between the two deformities.
Right. And then last but not least,
Last but not least,
what age should patients start coming to you? When should our wonderful providers refer to you?
Well, great question. I think that I'm always happy to see a patient no matter what their age. There's not a wrong time to refer someone. Some people just want to talk to a specialist to get counseling because they think that something's horribly wrong or they're going to need immediate surgery on a 2-year-old or something like that. There is no such thing as an emergency Pectus surgery. It is in the right patient, it's the right thing to do. But some people want to counsel before, or they just want to get a lay of the land, and then in patients who I think are like 10 or 11, because you really shouldn't do a NUS repair in someone that age. In those patients, I think they get good counseling. I see them back every year until they might be the proper age or till they've decided that, oh, yep, I am having symptoms, I'm having problems. And in those patients, you've known them for a while and that sort of thing. So even in the infants, it's not a bad time to refer if the mom or dad are unclear with regard to what is this, how do I treat it? And we can give them a lot of valuable information, even though we're not intervening.
Great. I think I'll turn it over to our physician liaisons.
Thank you, Dr. Mazziotti. That was really great information.
Thank you.
Thank you, and thank you all for attending today's event. Please visit Texas Children's Hospital Provider Resource link to register for our upcoming educational event on Tuesday, July 27th, Spotlight on the Young Athlete. And before you go, please take a look at the various resources Texas Children's offers to help facilitate referrals and connect to specialists. We truly appreciate your partnership, and thanks again for coming today. Bye, everyone.
Bye-bye. Have a great afternoon.